So we just come up here and just click that thing and away we go, right?
Yeah, this one
Yes.
is works,
Yeah.
right?
Yeah. Okay, so just it's on that stick
No need.
and it's under 2023 travel.
Attention to travel.
Yeah, and then are you doing the PDFs or I can work on here?
PowerPoint's better. This one
Okay,
here,
yeah,
by
yeah,
stream. Okay.
yeah.
I'm just gonna put it in here.
There you
This
go.
is our old presentations.
Yeah. And so that should come up.
That's right here. So when you come on, I'll be around here for help. But if you're able to just pop it open and then start this PowerPoint, you should be all good.
Yeah, okay, just go into like presentation mode sort of thing.
It should be do that automatically.
Okay.
If it doesn't, then if you know how to do that, that would be
Yeah.
good. But it should be doing that automatically. Look at that.
Do you check if it's recording?
No.
Thank you.
Yeah, no worries.
Record. Oh, recording. Yeah, it's recording already. But it says, oh, recording on his computer.
Thank you all for coming. It's great to see you. So glad you all made it here today. It's our first time back in Calgary in a couple of years. And my name is Michael Overview. I'm the director of Science Capital. We've got a great team, Marcella here, and many volunteers that are here to help you. We've got badges and fines and Indigenous peoples in this Treaty 7 region and the Métis Nation of Alberta, for whom this is an ancestral land, as well as the First Nations that continue with, whose presence continues to enrich our communities here. I'd also like to thank our sponsors, Innovate Calgary, BRIN, Thermo Fisher, Biomedical, Zemp and ACAD, Calgary Economic Development, Bennett Jones, and the universities. Got a busy morning, got 10 pitches this morning, and I just want to tell you about the process. It's a friendly and formal way to get feedback to teams who are looking to grow here in Alberta. You can either fill in the evaluation form if you wish on paper. We prefer if you do it online. Online, you just click on the company name on DiscoveryLab.ca and you can log in password. That is bo-medi-26. That gets you to the dashboard. You can fill in information, give them comments about what they could do better, if you want to contact you. We provide that in an anonymous form back to the teams, and if you put your email and phone number, whatever, you can also do that. Okay, if you need paper form, just raise your hand. The volunteers will give you paper on it. You're joining us. All right, so in the afternoon, we also have 14 more virtual pitches. We are recording this session to bear that in mind. Those recordings are then shared with the investors and the advisors who couldn't make it here except on a private YouTube video that allows couldn't make it here today to hear about the great stories of the person. I'd like to introduce Patrick Matern, who's going to welcome you to this meeting officially. His career has been dedicated to supporting the community through economic development. He spent 10 years with Global Affairs Canada and 11 more years with the government of Alberta, engaging in investment attraction and international trade. In 2019, he moved to Calgary Economic Development as Vice President of Business Development, attracting new businesses to Calgary and helping local businesses access global markets. Can you hear me at the back? Am I okay? Okay, good. And in 2023, Patrick took on the role as a senior business advisor to the executive team here. And it is my great pleasure to introduce Patrick here to welcome you today. Thank you, Patrick. Thank you
very much. It's always fun to talk to a crowd that's not oil and gas. I can tell right away, limited jeans and no golf shirts on a Friday. I don't know, it's amazing. But one thing, you may not have been to the Bow Building before, but you're sitting in an architectural art piece, really. If you know Norman Foster, the architect, this building, very much like the Hearst Tower in New York and the Gherkin or Swiss Ray Tower in London, very much the same structure. He's also gone on to do the Cupertino campus for Apple, the Apple Center, and I think the Reichstag in Berlin as well. So it's a unique building, and we're happy to be a tenant here. And we get a chance to use the 54th floor once in a while. Unfortunately, we weren't able to clear the smoke out for everybody, but we'll do what we can. So good morning and welcome to Calgary. Welcome to the Bow Tower. And of course, welcome to the Alberta Diagnostic and Medical Device Summit. Calgary Economic Development is proud to be a partner of this amazing initiative and brings together great minds in the fields of diagnostic and medical devices. Calgary's life sciences sector has seen tremendous growth in the past few years. We now have more than 120 life science companies developing innovative solutions in the field of digital health, medical devices, diagnostics, and of course, pharmaceuticals. We have witnessed successful launch of an operation of incubators, such as the Life Science Innovation Hub and BioHub X. Calgary has also welcomed world-class accelerators like Plug and Play, SVG Thrive, and Endeavor. We have an historical investments coming from the Strategic Life Sciences Innovation Center at the University of Calgary. And of course, we've seen the University of Calgary's ascent to be the #1 startup creator among Canadian universities. On the horizon, we'll see the new Calgary Cancer Center opening its doors to the public. Once it opens, it will become Canada's largest and North America's second largest comprehensive cancer center. It would not only attract top talent from across Canada and internationally, but it will also double the clinical trial capacity over the current cancer center. Last month, Alberta Health Services announced the plan to build the Centre for Research and Innovative Care on the site of Alberta's Children's Hospital. In partnership with the Government of Alberta, the University of Calgary, and Alberta Children's Hospital Foundation. This new center will ensure research gets embedded into the hospital and helps reduce the cycle time from research into patient care. Our Opportunity Calgary Investment Fund, which is administered by Calgary Economic Development, is growing the life sciences ecosystem with investments of over $20 million in accelerators, incubators, and participating with fund managers. We're also thrilled to see our provincial and federal government agencies such as Alberta Innovates, Genome Alberta, Genome Canada, and Prairies Can investing in groundbreaking pan-provincial initiatives like the Alberta Diagnostic Ecosystem Platform for Translation, ADEPT, and the Alberta Centre for Advanced Diagnostics. The unique combination of assets, resources, and expertise that ADEPT and ACAD brought together enables innovators to develop, test, and validate the diagnostic innovation and research time, in record time, pardon me. Today, we're going to learn more of some of the ventures that are born and grown in these amazing initiatives. You'll hear views of industry leaders, innovators, and clinical experts on how we can advance Alberta's diagnostic ecosystem and the opportunities the federally funded Prairie Hub for pandemic preparedness brings. We are thrilled to welcome our out-of-town guests, Thermo Fisher Scientific and Biomerio. They are industry leaders, innovators, and ecosystem supporters. I hope they enjoy the entrepreneurial spirit and the beautiful weather here in Calgary. Aside from the smoke, it's actually very nice outside. The generous support of Thermo Fisher, Biomerio, Alberta Innovates, and Innovate Calgary makes this event possible. Thank you for your generous sponsorship. The collective expertise, pioneering spirit, and visionary leadership in the room are the driving forces behind Alberta's success in the realm of diagnostics and medical devices. I hope you enjoy the summit and wish the summit a resounding success. So once again, thanks for coming out, and I hope your day is terrific. Thank you.
So one last quick bit of housekeeping before we get the pitches started. I'm Ian Lewis. I'm the director of the Alberta Centre for Advanced Diagnostics, and welcome you here. Thanks for everybody for coming. And it's great to see many of our ACAD and ADEPT supported businesses that are here today and going to be representing Calgary. We are at a really exciting watershed time right now, where Alberta is maturing in its capacity and its role from a place where it's primarily driven by focus on energy sector to a place where our health tech sector is increasingly becoming important. This summit is just one of a really exciting new swell towards this growth of this new sector. These companies are a good representative of it, and having representation from these multinational companies like Thermo Fisher and Biomerio is, I think, exciting step towards enabling this. I was going to say that some of the housekeeping for today, what we can expect is we're going to see pitches from some of our local startups here this morning, and this afternoon we're going to have a discussion about how to leverage this new momentum to establishing and growing Alberta's health diagnostics sector. So the momentum for this is that the federal government recently set aside $750 million for biopreparedness, biomanufacturing initiatives. And part of that is the Prairies Hub, which I'm part of the scientific leadership for. One of the 3 themes for this major investment is diagnostics. And the reason that we are leading this theme is because of the people in this room and momentum from these programs. I just wanted to say this is really exciting time in Alberta. There's a lot of support for growing this sector, and we're glad to be part of it. So without further ado, we'll introduce our first speaker today, Troy Feener, who is going to be representing Rapid Infection Diagnostics. This is one of my personal companies, so I'm not going to pitch on behalf of the company, and I'm excluding it from the pitch competition. So we're not looking to raise that $2,000 in reward for whoever wins the pitch. We're going to exclude ourselves. But Troy Feener has a history now of running some of the largest and most successful programs here in Calgary. He was he was part of Ed McCauley's group, which is now the president of the university. He was part of Andre Brieux's group, who's now the vice president of the university, or VPR, associate VPR now. And now he's running the ACAD program and this exciting company. So without further ado, Troy.
Good morning, everyone. Can everyone hear me okay? The mic is not too close. Awesome. All right, good morning. I'm excited today to talk to you about our company, Rapid Infection Diagnostics. As our name suggests, RID's mission is to dramatically cut diagnostic wait times for microbial diagnostics with the ultimate goal of saving lives. RID has grown locally here in Alberta, or in Calgary, out of over $17 million in investments, and it currently holds 3 patents in 5 countries around a technology platform that can identify microbial pathogens and accurately measure their antibiotic susceptibility profiles in a fraction of the time that current methods take. At present, we have developed 2 assays, one for diagnosing urinary tract infections and the other for bloodstream infections. We have been fortunate to have excellent partnerships to date with both Thermo Fisher Scientific for instrumentation and DynaLife Medical Labs, and we are grateful for their support in bringing our work to fruition. Our team is made up of a core group of research scientists noted on the right, as well as our executive leadership team made up of Dr. Ian Lewis, who you just met, founder of RID, who was originally recruited to the University of Calgary from Princeton, as the translational research chair for Alberta Innovates. Oren Mudaroglu, who is leading our commercialization strategy, and Dr. Diane Gregson, who is a world-recognized infectious disease physician here in Calgary. As I've mentioned already, the problem that RID technology is addressing are infections that can lead to serious life-threatening conditions such as sepsis. Our flagship assay, the BSIDX, is aimed at diagnosing bloodstream infections, which are one of the most common bacterial infections, over 500,000 cases and over 90,000 deaths per year in North America alone. Current methods for diagnosing BSIs still rely on classical microbiology growth methods that have not dramatically changed in several decades. The rate limiting step for these methods is the replication rate of microbes. This cannot be accelerated. It's hardwired in their genes. And while patients and doctors are waiting for the results of these tests, patients' infections are not waiting. For BSIs in particular, doctors must simply guess at the correct antimicrobial to prescribe. And every hour that elapses that a patient does not get the correct treatment, their probability of death goes up by 7%. Additionally, microbial testing is a major burden for clinical labs, with the numbers of tests performed by labs increasing, and at present, over 500,000 BSI tests and a staggering 21.2 million UTIs are performed in North America every year. This high volume requires not only significant infrastructure to keep up with demand, but also more personnel to operate that infrastructure. Alberta spends $15 million on approximately 1 million microbial tests every year to service a population of approximately 4.5 million people. RID has developed a solution to these burdens called the Hopper platform. It combines a proprietary microbial growth medium, a consumable plastic sampling device, and a high sensitivity, high throughput LC-MS instrument that is also a Class 1 medical device. Hopper can support multiple assays. And currently we have 2 tests, one for bloodstream infections and the other for urinary tract infections the BSIDX and the UTIDX. The core concept behind the Hopper platform is founded on the use of metabolism for identifying microbes. Hopper uses a novel diagnostic strategy, the metabolomic preference assay, which was developed by our CSO, Dr. Thomas Ridzak. This assay utilizes patterns of consumed versus excreted metabolites of ex vivo microbial cultures to both identify pathogens, ID, and to assess antimicrobial sensitivities, known as AST. When the assay is performed in the presence of antibiotics at varying concentrations, metabolism is dramatically altered or halted completely. As a result, Hopper can empirically assess minimum inhibitory concentrations, or MICs, in a fraction of the time that is needed by current growth-based approaches. And it's fast. In preclinical performance trials of more than 500 real-world patient samples for both assays, the BSIDX and UTIDX beat the current gold standard methods by 40 and 30 hours respectively. This has the potential to save up to 50,000 lives per year globally. And it's also small. Compared to the automated clinical microbiology platform used by DynaLife here in Alberta, the Hopper platform takes up minimal space and can be operated by a single technician. A single platform can service a large metropolitan region for all of its BSI tests. Hopper also does it all on a single device. Both our BSIDX and UTIDX assays work on the same instrument, and both do ID and AST with a single button push. To date, we can identify 57 organisms to species level, and unlike many of the competitive platforms emerging on the market today, our AST test returns empirical MICs, which means we measure the actual resistance of the organisms, not hypothetical resistance of the organisms, and that translates into higher specificity. Here's how we compare to the current gold standard platforms that are used in large and small microbiology labs around the world. These devices currently share a global market that's worth somewhere between $5 and $8 billion in diagnostic microbial testing. We feel that we are well positioned to capture a significant portion of that market, and we have a clear path to do so. At present, we have an operational Hopper platform installed at DynaLife in Edmonton and have trained their staff to perform BSIDX tests. We are working with regulatory consultants to assemble our pre-sub submission to the FDA by Q3 of this year. We are poised for revenue generation by the end of Q2 of next year. Today, we are looking for a $5 million US SAFE investment, that stands for Simple Agreement for Future Equity, for our BSIDX test. This investment opportunity will allow us to rapidly accelerate the development of our early revenue stream through LDT adoption of BSIDX in both Canada and US markets, while we simultaneously pursue regulatory clearance for wider adoption in broader markets. And we believe the opportunity has significant potential for return of investment, as only last year, Specific Diagnostics, whose Specific Reveal platform that performs rapid AST testing alone, was acquired by the market leader in this space, Biomedical, for over $400 million US. And with that, I'd like to say thank you for your time and attention, and I'll be happy to take any questions. We have some mic runners, so don't be shy. Anyone can, from anywhere in the room. Go ahead, Ayush, the top there.
Hi, thank you for the presentation. Just have some questions regarding your valuation and the deal terms. So
Sure.
$5 million safe, what does that look like? Is that a post-money safe? What's the cap on the safe discount rate? Can you dig into that a little bit?
You're actually asking the COO of the company. The CFO is probably more, give you a better response or more financial lingo response. But my understanding is it's pre-market. Maybe Gareth, if you don't mind, I can follow up on that question
Sure.
After.
Not a problem.
Better
Thank you.
detail.
No worries.
Thank you, Trey. Pardon me. With your first, pilot with DynaLife,
Yep.
What are you guys seeing as the best, most compelling aspect of your value prop that they're saying this is the best, this is saving us an incredible time, footprint,
Yeah.
Technicians?
Right. So the pre-assessment that we've done at DynaLife has been really about HR saving time, resources on that front. It's also very easy. A single technician, it's very easy to train. Our user interface is single button push with reports generated. The sample prep is minimal, single plate, enter the plate, gram positive, gram negative, wide variety of microbes that's many of the testing market doesn't cover. So we've got a lot of advantage for the DynaLife for the DynaLife staff that we're seeing right now. Okay. That's it. I will turn it over to. Oh, we have one more. Sorry, apologies.
Just popped in my head. So you've developed 2 assays.
Correct.
Are there plans for other assays?
Yes. So the great thing about the Hopper platform is it detects microbes, any microbe from just about any sample. It's a minimal sample prep and very short read times on the mass spec. So the sky's the limit as far as what you could do. There are applications outside of health diagnostics. There's environmental applications, there's veterinary applications. We see a broad range of possibilities downstream from this. Great. Thanks very much.
Okay, thank you all for your questions. That's great. Applause. Applause. First slide, so we've shortened it a little bit. Elliot's going to be the chair for this session. Elliot is executive VP at CoPoint, so thank you very much for chairing. This is a kind of a closed meeting, so your slides. Thank you.
Crocus
Biomedical. We're talking about some details about the differences of technology. Not very confidential, but we can get the support they need going forward. I'll let Elliot do the introduction.
Good morning, everybody. Thank you, Michael. I'd like to introduce Carrie Shemanko. So Carrie founded Crocus Biomedical, which is a University of Calgary-based startup that has developed a blood and tumor tissue-based molecular test for physicians to identify individuals at a high risk of bone metastasis. So please join me in welcoming Carrie.
Thank you. So Crocus Biomedical would like to fill in a gap in healthcare for breast cancer patients. And so when a woman is first diagnosed and treated for her breast cancer, at that point, there's no follow-up or surveillance, and it's up to patients to monitor their symptoms. So very often patients will come back to their doctor after a period of time with bone pain or even a bone fracture, indicating the presence of bone metastasis. And this is quite common. So 20 to 40% of breast cancer patients will experience the spread of breast cancer, which is called metastasis. And the majority of those cases will experience it in their bones. So here we have 6 survivors of breast cancer, and they're celebrating. But 2 of those women will go on to find that their breast cancer has spread, and one of them will find that it's in their bone. And this is a very painful experience, part of the disease. But if the metastasis is only in their bone, they actually have a good lifespan. And it's very important that we can try to give them the best quality of life as possible. So could we test all women with breast cancer for their risk of bone metastasis? And we have that first predictive test available. The time really is right for precision medicine. Breast cancer is one of the most common cancers globally. It is on the rise, in particular with young women. And healthcare systems are strained, in particular in Canada, where we have a public healthcare system. New advances have made it possible that it's a little bit easier to detect early breast cancers, but this is not something that will predict who will have bone metastasis. So there isn't a test available for that risk. And in particular, we might be able to save the healthcare some money and also improve the quality of life of patients. As I said, this is a very large market in particular. In Canada, we have over 26,000 women. and about 2,600 in Alberta. Our customers would be the physicians who would be writing, prescribing the test or asking for the test. It would be in Canada, the healthcare systems who would pay for that test, and patients would be benefiting from early intervention with treatment. It is possible to provide some treatment options prior to the diagnosis, and in this way, we wouldn't be over-treating patients either. And we may also catch the early cases. It's a cost-effective and low invasiveness test. We plan to do this in-house, and so we would be taking in patient primary tumor material at the time of diagnosis and also blood test that we would then use our unique algorithm to combine these multimodal biomarkers that we've developed over time and provide a report to the physician so that they could consider their intervention. So we have a multi-gene panel, blood marker panel assessing the tumor biology. And with our algorithm, we would put together a bone metastasis risk score result for the physician. And this would be so that the physician could consider perhaps additional imaging for diagnosis or consider treatment intervention. There's no direct competitors at this point. We know right now that we have a good test for the risk of bone metastasis. Some new data that has come out has also indicated that we may have a good test for risk of metastasis to the organs, to the viscera. And we're currently working on whether this test would also be able to have an early detection of either primary cancer or metastatic cancer. This has been based on a 10-year study that we established, and we've been waiting 10 years for the results to come out. So we're quite excited right now as the results are rolling in with our patients. It's possible that the test with further development might be applicable to other cancers where there is metastasis to the bone, and that's something that we're also exploring. This has been based on 20 years of my career and a collaboration with a machine learning expert. We're planning now to do our second stage prototype so that we can bring this together in a lab as a lab developed test and provide this to women. Crocus Biomedical currently exists with myself and Dr. Nancy Nixon, who's an oncologist, a clinical researcher, and she's also a co-creator of the Alberta Metastatic Breast Cancer Support Program. We know that we're going to be needing help, so we'll be looking for a COO who's passionate about cancer research and healthcare, in particular breast cancer. Our ask today is looking for that stage 2 prototype, in particular for the tumor diagnostic block. We're going to start with that as an early milestone, and to be able to bring that within a single corporate entity, and hoping to have space in one of the innovation hubs. Following that, we're going to be finishing the prototype for the blood test and putting all of this together for testing patients. So we hope to change the lives of breast cancer patients, and I hope you'll join us. So thank you for your time.
Just a reminder to keep filling out these forms online or on paper. If you need paper, let us know. The password again is O-May.26. The most recent program is online. Click on the company name, it'll take you to the dashboard, and that way you can give Carrie additional feedback after the Q&A. But I'll let you moderate the Q&A. Sorry.
Thank you for that presentation, Carrie. I'm just curious, what's your IP position on the biomarkers or in the company in general?
Right, that's a good question. So currently it is a trade secret. At some point we would anticipate putting that into a patent. It's, you know, with patents, you want to have the largest time after you submit that patent. And so with our 10-year program and prospective cohort that we had before then, we've been holding on to this before we do something like that. Yes, that's a good question. So So we have accuracy. So we've got two different tests combined at the moment. So we have an accuracy of 89, sensitivity of 84%, and specificity of 100%. And our blood test is 100 across the board with that. And the confidence level there is at 95%.
That's in the diagnosis of the lesion in the bone, or it's the condition of the patient will actually have it?
For the predictive risk. That's right.
For those predictive risks, how large is the patient population? How large was the trial? Based on how many patients?
So we had 500 patients that were enrolled. We used a special algorithm to identify those at highest risk within the cohort retrospectively, so that we could do the chart reading and confirm our diagnosis. So the blood test has been based on 100 patient blood so far. The patient tumor test has been based on thousands of patients, and we validated that in silico in 2 other cohorts. So we have quite a few more patients for the materials that we get from the primary tumor test. The blood test is a smaller cohort at the moment.
Carrie, does your blood test sensitivity and specificity change with the breast cancer subtype?
Oh, that's a very good question. So right now with 100 patients, that's something that we're looking at. And so it is a rather small cohort to look at the different subtypes. So that's something that we're also considering, is expanding to other clinically available samples that have been retrospectively, or that we can retrospectively analyze, but are prospectively collected. So very strong tumor samples that will give us the breadth of knowledge, so we can more definitively look at the subtype of patient that would best benefit from it.
We'll take one more question just in the back.
Thank you. Thanks for the presentation. I was curious to know about, does the metastasis from breast cancer, does it always end up in the bone, or is it, what's the likelihood of this ending up in other tissues? And is there a reason that bone was selected as the area to look for the other metastases?
Yeah, great question. So it's breast cancer will go to the bone in 70% of all cases. So it is a preferred site of cancer. It can also spread to the lung, liver, and brain.
And is there any way to detect or any plans to detect this in those other tissues down the road, or?
Yes, so we do have some encouraging results with respect to the blood test and metastasis, not specifically to the bone, and then also specific for the organs. So yes, so we're very excited to have seen that data.
Perfect, thank you.
We'll cap it there. Thank you so much, Carrie. So CliniSonix. I don't see here. Oh, here it is. Okay, great. So next up, I'm pleased to welcome Roger Zemp, founder of CliniSonix Incorporated, an Edmonton-based startup that's invented a scalable probe technology that significantly outperforms current 2D and 3D ultrasound scanners in terms of resolution and speed. Please join me in welcoming Roger.
All right. Thank you. So I'm Roger Zemp. I'm a professor at the University of Alberta. I'm also founder and CEO of CliniSonix. So CliniSonix develops and commercializes systems for automated 2D and 3D ultrasound imaging with, I hope to show you, quantum leaps in improvement in resolution, sensitivity, speed, intelligence, and breakthrough form factors. So one of the limitations that ultrasound systems have right now is that they have limited resolution. This is a pain point for a lot of clinicians. One of the reasons is that there's circuits called dynamic receive beamformers that limit the so-called numerical aperture to about 0.25. That's a measure of how well it can focus. That's like being stuck with a microscope with a 10x focusing power. So basically all ultrasound systems are stuck with that right now. And this is even worse in deep tissue because you have limited aperture. So why can't we go to higher focusing power? Now we can. Another reason is that simply the sensor count in ultrasound arrays is limited. Right now, it's like you taking a picture with a 32 by 32 pixel cell phone, and you get a pretty bad image. So if you had a megapixel camera, you get a much better image. So previously, ultrasound hasn't been able to do that, and now we can. So our technology comprises a novel transducer architecture and electronics. This is a novel material here called an electrostrictive relaxer. It's voltage switchable. And then we have rows and columns. So you need only to read out from the rows and columns rather than having a wire come out from every element. So I hope to show you some evidence that we are simply beating the pants off of most commercial systems right now. So this is a resolution phantom. So each of these dots is a cross section of a wire. So the smaller the dot, the better the resolution. So this is us versus competition of a volume imaging probe. This is us versus volume imaging probe. And see these points are just blurred together and we're much better resolution. In fact, there's ultrasound systems meant for small animals that have very high resolution for seeing fine structures in the animals. And we're simply better than those small animal systems, but we can go to clinical depths, whereas the small animal systems can only go down so far. So this is 21 megahertz probe. They have a little bit better resolution in this direction, but we have better resolution in the other lateral direction, and we can go down deeper. So in fact, our resolution is about as good as intravascular ultrasound, which, you know, you thread something up into the vessels to look at the vessel walls, but we can have that same resolution outside the body. So these are other examples where this is these phantoms to see these structures. So this is these high resolution systems. So we can bring better resolution, better image quality than these high resolution systems. So we can do micro ultrasound at clinical depths. Also, ultrasound systems have been limited in the field of view that they can offer. People have to really know what they're doing and look around. So if you've ever seen this cartoon of blindfolded scientists sensing an elephant, some people think it's a spear, some a wall. They're not seeing the whole picture. That's what this is like with ultrasound sometimes. So we are moving towards massive flat panel arrays. These are the competition. The data that I showed you was with these probes, similar footprint, but better resolution. And now we're moving up to these very large probes to be able to see whole organs, massive scale kind of images. So now we can see the whole picture. This is a previous field of view. This is the new field of view. And we can do this in volumes. Also, previously, ultrasound systems have been limited in their speed and sensitivity. And that's primarily due to the time of flight that it takes for a bunch of scan lines to form an image. And we're simply breaking barriers of speed and resolution. So for example, most systems go at maybe 30 frames per second. We can do 2000 ideally focused frames per second. We can do 2D or 3D power Doppler. with 50 times the sensitivity improvement compared to conventional Doppler, this versus that. And we can get these volumes of blood vessels at about 30 volumes per second on big scales. And we can do about 500 volumes per second, ideally focused everywhere. Also, previously, ultrasound systems were unable to provide longitudinal monitoring over time because people have to have a handheld probe scan around. So now we're developing tethered wearable. So these are basically Band-Aids that can do 3D imaging. So we think there's a lot of value here in monitoring cardiac output, stroke volume, right and left heart function, pulmonary hypertension, a lot of these things that could be done with this type of probe. So our technology pillars, we develop the arrays and the electronics. We license a commercial system. We have the ways of doing the imaging, the algorithms, and some of the GPU computing and AI. There's a lot of big market sectors here. Just ultrasound, clinical ultrasound alone is 10 billion. There's other markets that we can tap into, totaling about 62 billion. And we simply think that we can outperform a lot of these major companies. So these are some of our target clinical imaging sectors: abdominal, small parts, OBGYN, vascular, wearable, cardiac. We have value propositions in all these. So we're early stage. We have 2 granted patents, 4 pending, 5 in process. I'm not yet raising money. We have about 5 million in non-dilutive funding. I'm good at raising that money, but we're protecting our IP, maturing. Currently, I own all the equity. I have a team of me, Will, who's founded a few startups, and it's not his first rodeo. And then Mohammed's a graduating PhD student. Plus, I have a big other team of academic researchers. So right now, we think we have the technology to be a multi-billion-dollar company. Right now, we need to make sure that everything's in place. So we need the right business talent. So I'm asking for startup coaching, conversations, and a CEO willing to work for deferred salary or limited to 5% equity vesting over 5 years. So that's it. Thank you.
So we have fairly limited time for questions, just limited to about 2 minutes or so questions or so comments. Anyone want to start us off?
Sure. Yeah, thank you. You talked a lot about the incumbent competitors that you have higher resolution. I'm curious about there's a number of companies trying to address the resolution of ultrasound, including a local company from a UFC spin out, Novus TX. I don't know if you've heard of them or worked with them, coming out of Carrie, Shemanko, or sorry, Laura Curiel and Lab and Samuel Picardo. And they're doing a biaxial driving technique. I'm curious if the technologies could be combined or if there's some way you could work with that group to try and increase the resolution even further.
That's a mechanical scanning approach, right? So there are lots of mechanical scanning approaches out there, and let's simply stack up the data and see how we fare. I think we're better.
Question back there.
Thank you. I really like the presentation and the contrast there. Just curious to understand, are there hardware components that are going to make this challenging to price under competitors, or is this more of an algorithmic thing that is done behind the scenes to increase image contrast?
Yeah, so it does take a little bit of extra hardware, but we think we can be competitive about the same kind of cost per system, but simply do better. The probes are not expensive to make. It'll add a little bit more electronics. And now there's like ultrasound system on a chip, like 32 channels for $400. So that kind of stuff is really driving the cost down on the electronics side of stuff. Yeah.
Any more questions? Okay, great. Well, thank you very much, Roger. And we're going to be breaking for 10 minutes. So if everybody could please grab a coffee, water, please chat with presenters. We'll be back in 10 minutes at 9:57. Thank you.
There's coffee, little drinks served, so feel free to come back, hopefully 10 minutes, if you can. Thanks very much.
Sure, yeah. Do you have the title for the presentations for the next ones?
Yeah, Nanostics. Nanostics.
Hi there, Pierre. Oh, good to see you.
Okay.
Okay.
Get the wrong presentation.
So.
I just want to double check when you're all set up, that I got the right presentation on there.
Can you check in here?
Yeah, so it's the, it should have been the slides. No, mine's the Kent imaging one, but it's got the wrong.
Oh, you want to
I sent them
update
to,
that?
yeah, I
Okay.
sent them to.
Yeah, Q&A.
Okay.
So just grab that second last one there, yeah.
Yeah, I should do that actually.
Okay.
Yeah. I might just remind. So far, I think I'm pretty good. I'm also not.
Okay.
Thank you. I sent them two different ones, one to direct to people to review. I tried to put it down to 5 minutes.
Yeah, the other thing I gotta do
Okay, here, this was probably.
we're making a push to go into software to use the tool as a diagnostic tool. So we hooked up with the.
Let's go grab for some food.
But they, LKA, we're doing a project with them on this. So we're trying to do now is build a heuristic algorithm that takes like say Demerol. And then if you're looking at fentanyl, you'll see Demerol and say, oh, this is not a good thing.
Is that the next one? Oh, no, no, sis. Yeah.
We did. What are they doing? Well, I think they're doing. Well, I just want to
You gonna grab some food?
Right. So, well, we actually, okay, so we have replacement through the French, oh, sorry, through two companies. The French company does a pulse bundle that's 2 to 6, and then Quad Systems is a full-on high field system company. Sure. I think they go to 8. I think they go to 8. So it's replacement stuff. It's not good.
Yeah, I mean, I think.
Hey, everybody, we're going to get started in about 2 minutes. 2 minutes, if you could please come back from the coffee.
Well, I just. Yeah. Yeah, in essence,
Try to change the slide, but it doesn't.
That's not good. Okay, thanks everybody for the short turnaround and the break. Michael and I were speaking earlier. We're going to do a bit of a catch up. We are running 10 minutes behind. We're going to make that 10 minutes up as we go
sorry. Combines both clinical information and biological information to create risk scores of disease or probability of disease. Often the biomarkers we use are proprietary. We have some proprietary biomarkers around this extracellular vesicle technology. But our goal is to put as much information into our algorithms as possible, and we incorporate non-proprietary biomarkers in our analysis as well. As you can imagine, something happened and the slides don't advance anymore. But as you can imagine, this approach is applicable to a lot of different diseases. But at Nanostics, excellent. At Nanostics, we're focused, our lead products are focused initially on neurological diseases. The first one is a prostate cancer disease that I'm going to be talking mostly to you about today, but we also have a bladder cancer test as well that's in clinical studies. We have two other clinical programs, one in immuno-oncology and one in cardiovascular disease. But I'm going to take some time to tell you about our prostate test called ClarityDx Prostate. It's 3 times more accurate than the standard of care now, which is PSA testing. It's easy to use, it's highly accurate, and it's got a lot of significant licensing opportunities, which we're going to leverage to grow and scale our business. So if you're not familiar with prostate cancer screening, so prostate cancer is one of the leading causes of cancer-related deaths in men and one of the most diagnosed cancers in men. Essentially, when a man turns 50 or has a more likelihood of having prostate cancer, they get recommended to get something called a PSA test, prostate-specific antigen test. If you have high levels of PSA in your blood, it could be indicative of cancer. The problem with this is 85% of men with elevated PSAs don't have any cancer at all. And this is because you could have PSA in your blood because you rode a bike too long. And the real challenge is this can lead to what's unnecessary biopsies, because biopsies are the definitive test for prostate cancer. And this involves 12 needles into the prostate. And because of the location of how you have to get these biopsies, this can lead to a lot of side effects, including sepsis, and in some occasions, as I mentioned before, even death. So the goal is to have a more accurate screening tool for prostate cancer so we can reduce the number of unneeded biopsies. And so we developed this test called ClarityDx Prostate. It uses both clinical and biological information to predict disease. I'm going to show you the results quickly of a study that we just completed of over 3,000 men. And basically we found is ClarityDx Prostate is 3 times more accurate than PSA alone at detecting prostate cancer. Here are the numbers. And we're using this test and this information now to go to market. Essentially what our go-to-market plan is, we anticipate continued PSA screening. Men with elevated levels of PSA would then go on to get our test, ClarityDx Prostate. That information will go back to the physicians, and then they can make a decision whether or not to go on to do a biopsy. We're as accurate as any of the other competing tests on the market, but we're more easy to use, and we have a quick turnaround time and a low cost of tests. These are some of our major milestones. We've teamed up with DynaLife Labs here in Alberta. We're preparing to launch our test this summer. We have a lab within their facilities. It's a lab within a lab model. We're getting that currently in the process of getting that test accredited by the CPSA, which will allow us to first provide our test direct to consumer, but we're also working on reimbursement to get this paid by the province. We've also teamed up with a company in the US to launch as an LDT in that market as well. We put together a very strong team to do this, and we're really excited to be able to provide this shortly. And currently we've raised money. We've got a safe round open. There's $355,000 left in that. That's to help us bring our product to initial sales, but that'll be quickly followed up with a larger Series A in the $20 million range. We already have investors in our data room looking at a potential lead for our Series A investor. And with that, I'll just open up the floor to any questions and be happy to address them. Thank you.
Kathleen, you're up. 2 questions, 2 people, 1 question each. Anybody?
What's the price of current grades? Projected price.
Sorry, can you use the microphone so that people online can hear you, please?
What's the price of the current raise?
So
And what's
the-
the price of the projected $20 million raise?
So the safe round is a 20% discount rate to the next equity round. And so that's what that current one is. And then the Series A raise, we're in negotiations of what the cap is going to be on that. So, I mean, I don't want to say now because we're in active negotiations but we're hoping, we're looking to raise 20-30 million. So, I mean, we won't give up more than 30-40% of that company. So you can figure out what our valuation is trying to target, but it hasn't been defined yet.
One more question.
Increasing the specificity? Yeah, so actually one of the interesting things about prostate cancer is this is all based on a biopsy. And the specificity of the biopsy alone is 83%. So by us getting 81, 82%, we're hitting the maximum specificity because, I mean, the biopsy isn't perfect. And so we're actually starting to hit that limit of specificity. So we think we can maybe inch it higher, maybe we get more data, but we don't think it's going to go that much higher just because of the limitations. You have to do, the only way to get more accurate would be to base everything on surgery, and that isn't feasible to do.
Quick question. Thank you. I'm a pathologist, so but not a prostate pathologist. You had mentioned that most biopsies are low-grade disease. Does your screening test distinguish between the low grade and the high grade?
Yeah, and I didn't get into that. So we've actually trained our algorithm on detecting what we call clinically significant prostate cancer. So one of the interesting things about prostate cancer is there's different forms of prostate cancer. If you have a low level or grade group 1 type prostate cancer, the recommendation is to do nothing because you're not going to die from that disease. So when it gets to the higher grade groups, grade group 2 or 3 and above, that there's a clinical situation. We've trained ours on grade group 2, which is 100% treatable prostate cancer. That's kind of the target of our test. We can also detect grade group 3 and above more accurately, but really it's that grade group 2 that we're targeting.
Cool. All right. Cheers. Thank you.
Yep.
Of all the people identified as men in the room, does everybody know what their PSA score is? Yeah. Yeah. Okay. Get on that. Really pleased to now introduce Kathleen from Waveview Imaging. For those of you, we already heard one breast imaging pitch today. This is number 2. Again, back to putting the citizen-centered lens on this. My mom's a 20-year breast cancer survivor. I have 2 younger sisters. Both of them have had breast cancer. One is currently going through it. This is a really personal thing. What's interesting about what they're doing is, and we were talking about this a little bit beforehand, the use of microwave in imaging has not, was it 2008? That was the first use? No, 80s, you said. First experiment was in the 80s. So it's wonderful. Like I come from the imaging world. It's amazing to see how things have evolved. So really excited to get you up on stage. Cheers.
Hello, everyone, and thank you so much for having me here today. I'm very excited to tell you about Waveview Imaging's new approach to breast imaging. So to start, I think it's fair to say that nearly every single person in this room has been impacted by breast cancer, whether you've gone through it yourself or watched a loved one's battle. 1 in 8 women will develop breast cancer, and 1 in 34 will die from it. The reality is that too often breast cancer is detected too late. So what is causing this problem? Unfortunately, it's complicated. It's multifactorial. The first thing is a lot of women aren't coming in for their screening. 35% of women don't get their regular mammograms. And this has several reasons. It's accessibility, it's discomfort during scans and maybe avoidance, it's long wait times. There are all of these factors that really lead to this late detection that we're seeing. Another stat I want to point out is that 11% of breast cancers are found in women under 45. And these are women who do not get regular screening as per Canada's screening guidelines, unless a risk factor seems to get them in a little earlier. And why aren't we screening these women? Well, because breast cancer is less common in these age groups, we tend not to implement mammograms. Unfortunately, as our previous colleague Carrie mentioned, we are seeing an increasing rise of breast cancer in younger age groups, which is concerning. The last stat I'll talk about is that 43% of women above the age of 45, so above the screening age in Alberta, have dense breasts. Now, what this means is that if you have high density breasts, oftentimes that mammogram is less effective, and it's not catching a lot of these smaller tumors that really go undiagnosed. And unfortunately, it's not until that tumor becomes a palpable lump or other symptoms of the cancer that these cancers are being caught. So our goal at Waveview Imaging is to detect cancer earlier. Now, our device is safe. It uses non-ionizing radiation, as previously mentioned, microwaves. It's portable. It can be put in a carry-on luggage and brought anywhere it needs to be. So actively trying to address that accessibility issue. It's comfortable. 90% found it more comfortable than mammography during our preclinical studies. And the results are immediate. Not only that, but of course, it's simple to operate, really simple to train and implement into clinical workflow. In terms of our advantage, now, one thing I do want to make clear about this is that we are not trying to replace other imaging modalities. We are trying to add a tool to a toolbox to improve cancer detection. The one piece that we believe we can really improve on, in addition to that accessibility, simplicity, low cost piece, is that microwaves are being studied for the potential to improve contrast in these dense tissues. So between your fibroglandular and your fatty tissues and tumor tissues, we are able to differentiate between those using the average electrical permittivity properties that we're measuring. So to give you an idea of our current position, we have roughly 300 plus scans in volunteers showing really great consistency. We have 3 upcoming studies, one for monitoring chemotherapy progress at the Tom Baker Cancer Center, one for actually being able to compute breast density scores and be able to provide this as a service for women everywhere, and third, that ultimate goal of being an adjunct screening tool to support that early detection. We have heard from so many oncologists and radiologists that this is a need, and we have patient surveys to confirm that women are interested in this service. We have partnerships with physicians and with clinics who are really looking forward to piloting the device once it becomes commercially available. In terms of our IP, we have a provisional patent filed and more IP to come. So in terms of competitors, there are other guys on the market for sure, but as you can see on the right there, their models are bulky, they're complex, they're expensive, and unfortunately, we're not imaging close to the chest wall where a lot of tumors end up. So in that sense, again, we're really excelling in terms of our portability, our simplicity, and low cost. Our revenue model consists of the lease of the hardware as well as a software as a service licensing, bringing in reoccurring revenue with each scan. So in terms of the market, we really have a stepped approach to getting that first revenue. The first would be for those density assessments. Second would be the monitoring of treatment so people know how their chemotherapy is responding to neoadjuvant treatment. And the third, of course, is that adjunct cancer screening. We have a great team of supportive individuals with a lot of knowledge and background in microwave imaging and a lot of great advisors who are working hard to make our device a reality for women everywhere. We are raising $1.5 million private and $1 million in grants to clear our device for breast density assessments and start generating that revenue. So thank you for being here today. I really hope if you have any questions, I'm here to ask. We're really excited about this technology and hope you are too.
3 questions, 3 minutes, 1 question each, please.
Hi, quick question. Can this be used in a family doctor's office or is it dependent on a radiologist?
Right now, we have the device being operated by a registered nurse. What we do envision, though, is yes, implementation in a family office, and that's because of the low footprint. It can be easily rolled into the clinic. In terms of image analysis, again, that will depend on the application. For cancer screening, yes, that will be a radiologist, but for the aforementioned applications, absolutely. We really want to make this accessible and easy. You know, you go into your family office and you're offered a quick scan.
Multidisciplinary family practice clinics.
Thanks for your presentation. So since it's microwave technology, I'm wondering, is there any heat generated in the tissue?
No, that's a good question. I think people oftentimes hear the word microwave and they think, are we heating people's tissues? Not in the slightest. The microwave energies that we're using are about 100 times less than those used by your cell phone to give an idea of the power generated.
Thanks for the presentation. Just curious to know if you've had any discussions around CPT codes or compensations from physicians to, get compensated for analyzing these images?
Yeah, great question. To answer that, we are actively pursuing that right now. Reimbursement codes are tough. They take a long time to get. We're looking at generalized codes and seeing if there's a way to bill for this service. Keeping in mind that that is obviously a strenuous process. We are trying to keep costs as low as possible, looking at something like $50 a scan in the event that it starts out with patients paying out of pocket. But again, we are really hoping to get in for that reimbursement code and actively pursuing it. Thank you for that.
Thank you so much. I have one last question, just because I most recently came from the health benefits world. Do you see this? And you mentioned copay. Is this a health spending account thing?
I'm not sure.
Not yet.
I'm not
Maybe.
sure yet.
Don't rule it out.
Yeah, a little too early for
Never
that.
just rely on the provincial body to pay
Yeah,
for things.
yeah,
Thank you so
that is
much.
very true. Thank you.
For our last presenter, next 10 minutes, Pierre Lemire from Kent Imaging. One of the things I'm really happy to be introducing, right up here, microphone. Sorry, everybody's online, right? So I don't care for the online crowd. How many people do you have online, Michael? 20. Okay. Hi, everybody online. Was it 5-6 years ago?
I don't know.
Well, when did we first meet?
Yeah, 6 years ago.
Yeah. I mean, it's always nice to see when you've got a legacy within an ecosystem, like how companies have evolved and unfolded. And your platform technology that's now got multiple clinical use cases, right? But have also grown tremendously because of how you've looked beyond the Alberta market. So really excited to introduce Kent Imaging and to sharing where they're going.
Thanks very much, Peter. It's my pleasure to be here and maybe just give you a little background on myself. I've been developing applications for over 35 years. In the last 20 years here in Calgary doing medical imaging. And with my previous company and with the current one, I've got extensive experience in getting reimbursement codes. Please talk to me because I've scars about, I'm on 5 or 6 consultants to get reimbursement codes and are finally pushing through. We got regulatory clearance in over 12 countries in the world, including Japan, South Korea, and so on. So those of you who know me in the past, I'm happy to share my stories because it's been a long road, and if I can make your path shorter, I'm happy to do it. I'll tell you about 3 applications that Kent is focused in at the moment. The first is wound care. Chronic wound is a big problem, and if there's a way that we can give wound care clinicians better tools to assess what's happening in a wound and prevent amputations, that's a big, big deal. And it's a big problem in the US. That's where we're primarily focused in. Over 12 million diabetics with chronic wounds on a yearly basis. That's a problem in Canada. And it's a global problem. And when we look at the things that cause wounds to not heal, obviously oxygen is a key one. Oxygen is the key to life. Having oxygen in the wound is critical. Second is bacteria. It gets in the way as well. And the third is, and probably the most important, is the adherence of the patient to the treatment protocol. If they don't adhere to the protocol, they don't wear their offloading boot as long as they need to, et cetera, they will not get a good outcome. And so there have been other technologies to try to assess oxygen, but they require dyes, they require leads, they require the patient to sit for a long time, or they require a technician who's been specially trained in order to use the technology. And our product there, as you see, is like a digital camera, but it uses near infrared light to assess oxygenation. We look at the amount of oxygenated versus deoxygenated hemoglobin, and that gives a clinician a much better insight to what's happening in that wound. Just like when you go to the doctor and you suspect you have a broken arm, you send them for an X-ray. The same thing now we can do with wound care, in that we can now provide imaging to the clinicians who are treating wounds. But it's also important for the patient to understand what's going on. And so we can show these images to the patient and say, do you still have inflammation in that wound? Do you even have enough oxygenation in the first place? So we need to send you for a vascular referral to get that treated. And so we're seeing the compliance to therapy going up significantly because we can get the patient and their family involved in the process. So here's an example. We're in Mercy Wound Care in the United States. In 2021, prior to using our technology, they had 374 diabetic wounds. Their healing rate was only 52%, and their amputation rate was 12%. After adopting our technology, their healing rate went up to 72%, and their amputation rate went down 7.6%. So the technology is having significant value, and you can see how that can change outcomes for patients and reduce healthcare costs. Second application that we're looking at is peripheral arterial disease. This affects over 20 million patients in the US, and a lot of times they don't know they have it until it's too late. And so we're using our technology to screen, and here's an example. The images on the left-hand side are for the initial visit, and the top images represent taking images of this patient, top and bottom of their foot on their, with just in resting position. Red means good, blue and green is not so good. You can see in the top image, it looks like that patient has good oxygenation, but we're actually being fooled. So we do a provocative maneuver where we raise the leg for a minute, we re-image, and you can see a significant change from red to blue. That means that patient has a significant issue and they should be referred to vascular. In this case, on the right-hand side, you can see what happened post-stent, right? Very good outcome, patient went on to heal. Third application is in plastic and reconstructive surgery, where surgeons who are doing mastectomies and then doing the reconstructive surgery need to have better tools to understand what's happening so that they get better outcomes. Too many women are having complications post-surgery. It's enough that they're dealing with breast cancer. The fact that they have to have additional complications from the surgery to help them with that is a real problem. And so we're working with clinicians to solve that problem. Same with colon resections. If your colon resection does not work well, it can be catastrophic. We're supported by TVM Life Sciences. I was able to raise 15 million US to fund our go-to-market strategies. They've been very supportive, and with their financing and support, have been able to build a very strong team here in Calgary. I have 2 chief medical officers, one for wound care, one for plastic surgery, and we have a very strong team to go to market. Currently selling the product US, Canada, in Australia, Israel. We're working on CE marking. And if you're thinking about CE marking, please talk to me. It is a 2-year process right now. And so you got to start now and think ahead of where you're going. They asked today, so one definitely to share the story, but anyone who can partner with us to help us commercialize the product and evangelize it, we'll take any partner. We've got lots of partners, great partners around the world, but I certainly would like to see this technology being used here in Alberta. And we'll be doing another a Series B round later this year with TVM as the lead. So if anybody wants to partner with them and help us take this technology globally, I'd love to talk to you.
Great, thank you. Last one before the break, you got a 15-minute break at 10:30. So 3 questions, 3 people. Who's up first? Elliot.
Thanks for the presentation. Could you talk to us, sorry, pardon me. Could you talk to us a little bit about the revenue model and how it compares to competitors?
Yeah. So we've had to be really flexible with the revenue model. So we do have a CPT code. It's category 3 in the US. Some of the MACs are paying for it and paying well, paying about $60 per image. Others are saying it should be part of just the E&M visit. And so we sell it on a capital purchase or leasing purchase, or we'll even rent it to people depending on what works for their model.
Number 2.
They just want coffee.
They just want coffee. Raja?
Here's the obvious question. Ideally, adoption in Alberta, what are maybe some of the
barriers that you've been hitting?
Yeah, I don't know where to start, Raja. I will say, it is actually being used by Dr. Temple Oberly at Foothills, doing in her reconstructive surgery. She's done some great papers and published on the technology. We offered to give the technology during COVID to help, because people with wounds didn't want to go to get their wound care, and as a result, they're ending up in the ER. And so we offered to give 6 devices to both Calgary and Alberta, Calgary and Edmonton, to give to nurses to do home care, and the nurses just didn't have the time to adopt it. So I'm keen to spend time and make it happen. You know, the reality is it's a heck of a lot easier to sell in the US, and that's where we have our time.
So I'm going to play off of that and ask the inverted question. When you began in the US, you had a clinical network that you'd already established because of your previous company with Calgary Scientific. And you also had clinical experts to come and help you establish those luminary sites. But what advice would you have to everybody in the room on the realities of procurement in a very fragmented US healthcare market?
So I wish I had all the connections from Calgary Scientific to help me with this company. I had to rebuild. And so we looked at who are the top wound care doctors. We went to trade shows to find them out. And from there, once you get a couple of the key opinion leaders to use your technology, then the others sort of follow along. But certainly the biggest issue is reimbursement. And the second is reimbursement. Yeah. And the third is getting paid for your reimbursement code. Yeah. So again, if you can get one of the MACs, a MAC is a medical administrative zone, because in the US, Medicare and Medicaid is managed by different MACs across the US. There are 7 different zones. And so one of them might pay, and another one will say, as I said, that they're not going to pay. And so you need to find the one's going to pay and go after them hard and leverage them to get the others to pay.
Cool.
Hope that answers.
That's great. Who here is actually already in the US, whether it's for clinical trial or commercialization? Okay, like a few of you who want to be there in the next 3 years. Okay, I'd say a few other people. That's great. I did the same thing for a couple of companies. It is a hard slog, but really understand that the US healthcare system is super fragmented. One of the things that I'll pick up on, just to ask a final question before we go to break, for those beyond reimbursement codes, there's also, which is physician specific and clinic specific, there's also something called Medicare Plan B, which is looking at value-based care, sometimes looking at chronic disease management through primary care offices. Have you started dabbling at all in looking at value-based care reimbursement with Plan B?
Yeah, we have started to look at that. It's actually a lot easier to go to the VA where they don't have to worry about it. Although what I found this year was interesting. The VA does look at what Medicare and Medicaid pay, because if they can bill it to them instead of the VA paying for it, they'll do that.
Okay.
Yeah, I think we still have a ways to go though, Peter, to take advantage of that specific program.
Okay. Yeah. Thank you.
1:45?
Okay, 15-minute break, 10:45, please. Thanks very much.
Are you like sharing the next session?
Yeah, I'm starting. No, I'm not chairing. I'm the first guy up.
Oh, okay. So where's your?
Yeah, I'm this guy here.
Oh, okay.
So I was just gonna fire this up and
No,
see
it's
it.
okay.
Just see what you see on here
Can
is
I-
what I really want.
Yeah. So I got yours. I'm gonna number them, so I'm gonna put it up before you come up, or during the time that you're gonna be introduced.
But this is the first one, so you can.
Oh yeah, actually, yeah, I'll do that.
Yeah, I just
Get it
wanted to-
open and.
You can use the clicker, or you can use.
Yeah, the clicker didn't work for that last guy, so maybe I'll just
didn't?
I don't know.
Oh,
It works, like,
it
nobody's
works.
using
It's
it, I
just the reasons because I clicked on the Zoom settings and then it clicked using the Zoom
Oh,
settings.
okay.
Which is not gonna do anything.
Oh, okay.
Oh, can you help me find?
Yeah, sure. It says Discovery right here. The one that says.
Number 6, 7, or
So when that goes, yeah, I'm just seeing like, are you seeing? Okay, so you just see, oh, you get to see the little words.
But you can see here.
Oh.
Goes in presentation mode, like.
Okay, nice.
This is what you see.
I
but
wasn't sure because I have a couple notes and I wasn't sure how the hell this worked. If I'm gonna be looking back or whatever, right?
Yeah, sure. And yeah, works fine. So it should be okay. Let me try to do this. Let me try to do this. Some weird thing going on. So when I hide this, I'll do this. Yeah. Okay. Cool. Okay. Okay, sweet. Okay, so I'll have it up right
Yeah,
away.
thank you, thank you.
Right. Yeah.
So next one is like.
Discovery.
Individuals here. Thank you so much. Appreciate it.
We don't know what's funny. It's actually someone who started a company a year ago. Yeah, this one, yes.
Claire sent hers to Michael about an hour ago. So
Okay.
we need to get it from Michael.
I'm chairing the next session, so we'll talk.
Wonderful.
Just to make sure we have it.
Sure.
Yesterday. Yeah. Okay.
So we have the presentations we need to do. And
Oh, they're together.
we don't have it.
Yeah.
Oh, I thought it was-
No, we're so- Yeah.
Michael needs to tell us the chat. Michael, I'm sorry to interrupt you.
Okay, sorry.
This sheet is not.
Yeah, they got it one more. So this is correct. So what we have is, yeah, like I update on my basically all the time. There's a PDF and also the homepage. So this is correct. Yeah, and I wrote it down. I also do. So Casey is, okay, so you're doing John and Amir. His Matt dropped out, but I made a Ashani for BioSenta is the last one. You're not doing it.
And
And Julie couldn't play it.
and they're missing two presentations.
Yeah. Oh,
These two presentations, she sent you about an hour ago.
okay, let me download them.
There's two from here.
Yeah. What are you firing up first there? Do you have a thing or do you just?
I'm relying on these two gentlemen to let me know for that. I think you're going to, are you guys gonna load it up for us?
Yeah.
Okay.
Should we load it?
We're
We are currently waiting for 2
They're
presentations.
downloading the presentation.
As soon as we get them, we are gonna.
Fire it up.
You're ready. You got this. Unless you're nervous, then don't. Yeah.
They have all like the good thing about this, like they have pretty much everything set up.
Right.
You know you're in a good place when you don't need to bring anything. They have all the cables, the systems prepared, everything. It's an amazing venue.
Yeah.
Sure.
Not worried. Oh, do they have this table and this?
Every time
this
they,
adapter?
oh, we don't have this. The guy was like, oh, I got it.
I'm gonna grab one thing in my bag here.
Okay, perfect.
And we have like, I don't know, like video and audio system in place. Like we don't have to do that.
That's great. And that all works to Zoom then.
Everything is connected.
Excellent. That is the best. Okay. I'm assuming you're gonna want to load up the presentation before I call everyone back in. So.
Yes.
Okay.
Let's see if we can track what the next presenter.
It looks like this. But I don't understand if it's I'll just go into the loop.
Yeah.
Oh. Oh, okay.
Okay, 2 of them didn't even.
That's what just hurt. So this one is not checked in.
Only there they check. Yes.
So this Pierre's not here. Okay. So am I introducing Pierre?
Michael is working on getting her presentation. So we.
We're not starting yet. We're waiting a few more minutes.
Yes.
Okay.
Once Michael shows up and
Then we'll
yeah.
Very nice lady. It's okay. Okay.
Yes, we can Michael.
Where is Michael?
He's in. If you need to find him and he's not here, he's in the office directly in front. Yeah.
Cool.
That would be A. That's Claire's.
Okay, Roxy said that he thinks that Mehdi's presenting. I'm guessing, because he's presenting not for his company, and he's not on this list.
Oh.
So.
What is Mehdi? Yeah.
Okay, Roxy's gonna go.
She's gonna. Thank you.
Because we do have Mehdi.
We do have Mehdi's. Which one is it? I don't remember, but
I don't
we
know,
have it.
he's not on this list, but he said he was
It's BioSenta.
presenting. Oh, it's for BioSenta. No, that's not the company, right?
Biomedical company.
BioSenta, this one
Bio-
here. This is Mehdi.
Yeah, so then that's not it.
Yes, this is Mehdi. This is Mehdi's. The BioSenta.
Yeah, but that's not what it says. Well, I know, I guess it says, I don't know. There's nothing.
So remind me, Kent, not Kent. Which one is the next one? It's DiscoveryLab. I'm gonna keep this up for now. See. Oh.
Fire up full screen mode so I can look at my first thought, what I'm supposed to say here. Okay. Then at least I figure I'll get my first slide right, like my name. But no, is this thing on?
Yeah. If you ever want to just like yell at somebody in private,
Yeah, I know.
I love you all. There you go.
This is it here.
And if you want to use the clicker, also you can
Up and down.
Yeah.
Oh, it can or left and right. Both.
Yeah.
It depends on if you use the left side of your brain or the right side.
I use it.
No, left and
Yes, it does. It works. Yeah.
Oh, this is okay. This presentation. It was working on the PDF.
I'm looking for Amir, our speaker in about 10 minutes. Amir Sanata Nazab, the CEO of Criticare DX. Is Amir here? Okay, I think Amir may not be here yet, so we're gonna have a switch in the schedule. So feel free to find your seats. And Amir will be replaced by Claire Dixon, the co-founder and CEO of Neuraura. And KT Mertens will introduce our next two speakers, if that's okay. So we've got BioStream and then Neuraura, okay? And I think, yeah, Katie's here, great. So, and our next chair is Katie from Alberta Innovates. So thank you so much for your help today.
Alrighty, hi everyone. We're going to get started with our next session of pitches. So if you just wanted to have a seat, that would be great. Awesome, thank you. And I'm Katie Mertens. I work with the Health Innovation team at Alberta Innovates as an associate business partner. And I'm very excited to introduce our next presenter. We have John Murphy, CEO of BioStream Diagnostics Incorporated. They're based in Edmonton, and they have developed an organic electrochemical transistor-based platform for faster, more accurate diagnostic tests based on antibody binding target antigen for a variety of infections. So please help me welcome Paige. Thank you.
Thank you very much. Thanks for the opportunity to be here. So I'm John Murphy. I'm the CEO of BioStream. And I started this company in 2020 because basically waiting for test results from a lab was ridiculous. And they pointed that out. And then the second reason was that I thought I could solve a problem that doctors and clinicians have with point of care. And that is they have to use multiple devices right now. And they're training their staff on these. And basically it's just such a hassle that they say, forget it. And even though they also say that having a point of care test in their clinic that really worked would be fantastic. So the solution really starts with a point of care device that can deliver lab quality tests. And that means it's got to be results in 5 minutes, as accurate as lab tests, low cost, it's got to be portable, and it's got to be versatile with a lot of tests. And it can't just be any one of those, it better be all 5. Now that became possible when we developed a new breakthrough of transistor based on OECT, organic electrochemical transistors, that has a semiconductor that's designed specifically to exchange voltage with human cells. So we've got amazing accuracy, and the US government said, hey, this is great, but can you do 4 diseases at once? So we did a design for that as well. So the biosensor works with most liquids, so blood, saliva, urine, water, and targets things like proteins. You can do hormones, bacteria, this kind of thing. So very flexible. But then how do you get a lot of tests done? How do you get a lot of tests built? So we not only have our tools, but then we created our instruction set so that could go out to all the researchers. And now researchers can functionalize a little sensor. They can own the IP. They can set the price of this consumable, right? So this is just a disposable. And then we can also help them commercialize it, because we can put it up into our marketplace. Everything that from all the devices comes, it's Bluetooth enabled, so it's up to our cloud. We're tracking everything. So we've got a lot of tool set to be able to make that work. From the clinician side, they're saying, okay, this is great, but now we can have one universal reader. We don't have to buy a different device for a different set of little tests, because we've got tests being built from researchers all over the world. Now, we're all familiar with this business model, although it's new to the healthcare system. So in our pockets, we've got phones with apps that are developed with third parties. They own the apps, but there's a universal reader called a phone. So we're providing a universal reader for the healthcare industry and for researchers that understand how to just functionalize a biomarker onto gold. The market size is huge. There's multiple markets: diabetes, infectious diseases, cardiovascular. There's multiple multi-billion-dollar industries. And so obviously when we can't attack all of those at one time as a platform. So we're engaging with partners who really understand biomarkers and in a couple different niche industries. Does it work? Sure, it works. So we've got data to prove it works, and we're building more all the time. This whole technical validation piece right now is critical. And so here's just some data on CRP, C-reactive protein, and we can get into that a little bit more. On the go-to-market strategy, we're not going to eat the elephant here at one time. We're looking at, we're selling a kit to researchers. We're engaging with industry right now. Some of the folks that we're talking to are actually in the room here. And then secondly, I'm raising a Series A round later in the summer, which I think I pretty much have circled. Okay. And then we're also engaging with customers who are looking at applications that are going to need full FDA, Health Canada compliance to be able to sell. And that's where the real money comes in. So I have a pretty clear path to about $100 million by 2028. This is a global play. There's competition. Right now we can compete on price, we can compete on accuracy. But in 3 years, I can tell you that's just going to be table stakes in this industry. Where we're going to have pulled ahead is with that network effect, right? Because the large companies are going to have a hard time if they've only got dozens of tests, and we've got a world of researchers building out for us. We have a team to get this done. My co-founder has built a diagnostic company, a cancer diagnostic company out of Vancouver. Our CSO here today, Dr. Shiraz Bosch, Harvard, Oncology UK, University of Alberta, fantastic. Lee Marsh, Enterprise Systems. He's built sensors for Amgen, Canon, Fortune 500. I've built and exited software companies. And and I asked Al Berkeley to chair our board. Now, Al is the past president of NASDAQ, the former executive director of the World Economic Forum. And I asked him to, chair us, help us think globally, And then maybe even introduce us to some of his friends that are, part of that Series A group. So what I'm asking for today is $500,000 in front of the Series A, because I don't want to go into my Series A kind of empty-handed. I want some dry powder. I want some revenue that I can now get through these projects, and I want inventory for the product. So that's the story. If you're interested in impact investing in disruptive technology, and I think we can look at somewhere in a 100x kind of return, I'd love to talk. So questions?
Perfect. Thank you so much. We do have some time for about 3 questions.
Yeah, so some of the work that we did with COVID, we have specificity of 89% and sensitivity of about 92%. And we can get into more detailed data. Yeah.
Yeah, interesting concept, great revenue and business model. I'm curious, that one proof of concept that you showed with CRP, was that on whole blood or was that on purified sample?
So that was on serum. Shiraz, our CSO, is here. He did the work. We can kind of go into that in more detail, but yeah, so that was on serum and it had some real patient samples involved, but it was a low number of patient samples for that.
So I know we are competitors, we are in lateral flow. So one of the slides I saw, you said it requires amplification step. So is it something else sitting inside your reader or?
Yeah, no, so the amazing thing about this is as soon as there's a binding event between, like we functionalize this with an antibody, as soon as there's a binding event, then the number of ions to that goal gate change and we amplify the voltage. So the only amplification happening here is just an instant voltage amplification.
Thank you.
Yeah, thanks for the presentation. Just curious to know, do you have a lead for your Series A and what are the terms of the bridge round?
Okay, so I don't have, for our Series A, yeah, I think I have that circled with a group called the World Health Innovation Summit. So these are folks that we met with. They just raised $17 billion. And they see where we can kind of help with their mandate. But that's the 5 million Series A. Your question on the 500K. I've just started that. I just got the documents from the lawyer on the waivers that I got to send to the shareholders. So I'm just kicking that off.
Okay, perfect. Thank you.
We do have time for one more question. Raja.
Now you're in healthcare. How's it going?
You know what? It's hard. It's really hard. And sometimes it's like, what am I doing? So I guess, yeah, it's hard, but one of the shining things is that I don't really feel alone. And part of it is like things like this. There's an ecosystem. and honestly, I need help. We need help. But that help is here. And it's pretty encouraging. So I got to say, I'm pretty encouraged, but this is hard.
Awesome. Thank you so much, John. Perfect. Now we're going to transition to our next speaker, and it is my absolute pleasure to welcome Claire Dixon, co-founder and CEO of Neuraura, which has developed a bioelectronic wearable and is targeting polycystic ovarian syndrome. So please welcome Claire. Thank you.
Hi. Women with PCOS are 7 times more likely to commit suicide. Here's why. Debilitating symptoms that prevent them living the life they want to lead, serious and significant chronic health complications that rob them of years of quality life. I'm Claire Dixon. I'm the CEO and co-founder of Neuraura. We're unlocking bioelectronic medicine for chronic underserved health conditions, starting with PCOS. So PCOS is the most common hormonal condition affecting almost 1 in 5 women. It disrupts ovulation and the menstrual cycle and is a leading cause of female infertility. It increases insulin resistance. So 50% of sufferers will develop diabetes before the age of 40. Today, unbelievably, there is no effective, widely accessible treatment. So Loop will be the first. Translating what's been proven in high-quality peer-reviewed studies from the field of electroacupuncture, translated into a convenient, at-home, easy-to-use device. At a target cost of ownership each year of less than $400, compared to $15,000 if you were to do equivalent electroacupuncture treatments. Now, compared to the existing standard of care, first-line treatment is hormonal contraceptives. Loop actually works in harmony with the woman's body. So reducing insulin resistance, harmonizing menstrual cycles, and rebalancing hormones. With a razor and blade revenue model, the opportunity in PCOS is at least $7 billion. It is a white space, very large commercial opportunity. We're driven to get this solution into the hands of those who need it most as quickly as possible. So we've already confirmed a class 2 510(k) regulatory pathway with the FDA. With using pain as a predicate code, there is no need for clinical data prior to launch. And once in market, we'll progressively escalate claims for PCOS. Our primary channel will be B2B2C, working, and we're already in discussions with online pharmacy partners. And harnessing the power of an extremely engaged, well-connected, and highly motivated end user community, working with advocacy groups like PCOS Challenge, that has 67,000 active members in the US. Our impact doesn't end there. So what we're building is actually a scalable platform to treat a range of conditions ourselves, progressing to a weekly disposable that will be reimbursed for prediabetes and diabetes, and working with a growing list of partners for other clinical use cases, only 2 of which I can put on the slide, but there's more. If you think about passive wearables, your Apple Watch, your Oura Ring, 30% year-on-year growth in that market. Well, what if you could converge that with a wearable that actually delivers a therapeutic effect? What makes this all possible are micro needles. So for stimulation, they penetrate the outer layers of the dermis, overcoming the electrical resistance and delivering a much stronger effect than your standard TENS flat electrodes, but without damaging the skin the way stainless steel microneedles can do, or making a mess like gel electrodes. Now, for recording applications, they also offer incredibly high signal and spatial resolution, better than clinical gold standard in intracranial recording. My brilliant co-founders, Pierre and Colin, have been working on this core technology for more than a decade and span it out from the Hotchkiss Brain Institute, obviously a pioneering institution in the field of brain-machine interface. Now, I'm a mission-driven founder. I struggled with infertility for 8 years. I'm sure many people in this room also have stories they could share. But I also have 25 years of international commercial experience and a Harvard MBA. We're very fortunate. This is just a selection of some of our advisors. People like Christy, who's one of the co-founders of the Stanford Wearables Lab. Helen, she ran the Libra team at Abbott that developed the continuous glucose monitor for more than 2 decades. And Lisa, Dr. Stena Victorin, who is the global thought leader on electrostimulation for PCOS, the former president and current chief scientific officer of the AEP Society. We are currently raising a pre-seed extension, but quickly achieving what's on the screen in terms of what we're going to achieve anyway, leading into pre-sales with both channel partners and end users. We're looking for true partners, people who can open their network to channel referral partners, people who can support us in building brand and community. We're transforming the standard of care for these chronic underserved health conditions, starting with PCOS. Join us. Thank you.
Thank you so much, Claire. We do have a few minutes for questions, so we'll open the floor now. Great, perfect.
Thank you. That was a great presentation. I have a question for your primary outcomes for your PCOS studies. Is imaging of the ovary for a reduction in the accumulation of follicles one of those outcomes? And what were the results?
Our clinical validation plan is we're currently recruiting for informal studies that will focus just on insulin resistance, avoiding the cost and the timeline needed for those bigger studies. So we're doing that first informally. Our plan is to actually launch the product before doing formal clinical studies. They'll be progressive. So because we're launching for pain, we will do a side-by-side with a standard TENS. Pain is a difficult space, as I'm sure you all know, but we'll do the study anyway, more for the customer than the regulator. And then we'll do a formal version of the insulin resistance study. So it's only a 2 to 3 week study, about 30 patients. And then the study you're referring to, because we'll have to capture multiple menstrual cycles, and obviously people with PCOS have irregular cycles, it will be over the course of at least 9 months. There's various endpoints. Obviously there's blood draws, ultrasounds, et cetera, to track kind of what's happening to the hormones and to cysts. If they present with cysts, obviously we'd like to see a reduction in the size and the number, but also tracking obviously regularity of cycle and things like extreme dysmenorrhea associated with that as well.
Thank you for your presentation. I just have a question on the possibly biomarkers that you're monitoring. So are you monitoring the levels of biomarkers, and are these established biomarkers, validated in clinical trials, or are you doing biomarker discovery?
So we're aiming to have a therapeutic effect. The MVP that we release will be done, right? Will be for that pain application, it'll be extremely done. And then we will layer on more of the sensors into it, but we're also considering actually interconnection with some of the other existing wearables out there. We will measure glucose, like in terms of like the metabolic side of this condition. In terms of the menstrual cycle, we're still thinking about it. Frankly, a lot of the measures that people use today aren't particularly reliable. So measuring temperature from skin, et cetera, not very reliable for menstrual cycle when people are already self-reporting what their cycles are. So we're thinking very carefully about what to integrate that's actually going to be differentiated versus what's out there today. And we're working with, I'm sure you'll know, Danica and the team at MyNormative, we're working with them in terms of really thinking about that kind of long-term data strategy and how to build value there, not just for us and our end user, but also more broadly in the field of women's health.
We have time for one more. Yeah.
Thanks, Claire. That's really interesting and quite a neat innovation to treat something that is definitely a major issue for women. What I didn't get, and maybe you can comment on, is a proposed or a known mechanism of action.
Sure. So the quality of the evidence that it does work is much stronger than the quality of evidence of how it works. We are engaging with UMC in Amsterdam. They're looking to do a study with us in terms of doing some animal work, in terms of understanding the mechanism better. There are there. So it's believed to work at the local, the segmental, and the central nervous system level. So at the local level, when you stimulate, you increase the blood flow through the small microvessels in a muscle, and you increase the metabolism of that muscle. And so what you see is an effect within about 15 minutes, but it's like exercise, right? It's the same kind of thing as exercise. At the segmental level, and please don't ask me about nerve growth factor, it's one of like my blind spots, but through changes to the nerve growth factor, the rest of the skeletal muscle responds in a similar way in terms of increased metabolism, And then at the core of PCOS, the gonadotropin releasing hormone, the pulse frequency of people with PCOS is not the same as people without PCOS. And so it's believed to adjust that pulse frequency, which then affects the proportion of the luteinizing hormone versus the follicle stimulating hormone, LH versus FSH, which sends instructions to the ovaries and tells them how much androgens like male sex hormones versus female sex hormones. So that third layer really gets to the core of the condition. Yeah, that's the best out there. It's not as compelling as you'd like, but it's women's health. So, you know, you can, you know what's that's like. There's not that weight in many fields.
Well, thank you so much, Claire. Let's give her a round of applause. And I'm going to invite the next session chair to come up to do the last pitch for us. Thank you.
Hello, everyone. This is Mehdi Mohammadi. I'm working at university. I'm postdoctoral researcher, and my research focus on last couple of years on developing antibacterial agent, working with BioSenta company. I was asked to present yesterday, so it was like a limited time to prepare pitch, but I will do my best. So I'm so excited to share our progress here with you guys in BioSenta. And probably you may ask, what is this 1.27 million? So unfortunately, this 1.27 million is a number of deaths per year due to antibacterial resistance. And due to and also based on United Nations report, this number expected to be 10 million in 2050, which is show us or highlighted antibacterial resistance become a big threat for global health. And due to emerging multi-drug resistance called multi-drug resistant microbe called superbug. This real and major threat for health, and lots of like a paper and literature published to highlight this problem. But one of the major challenge right now is there is a lack of effective antibacterial agent that works for a broad spectrum of microbes. And on the other hand, developing antibacterial agent is very expensive, is very time consuming, and need lots of money. So in BioSenta, we are very passionate to work on this like a new product and new technology that could work for broadest spectrum of microbe and reduce this number of mortality and also work for superbugs. So we develop a technology or a microparticle called trifiller, and it's comprised of a core share material, and core is a calcium hydroxide, shell is a calcium carbonate, and works. It's considered as antiviral, antibacterial, antifungal particle, and also is stable up to 99 years through our accelerated aging. Also, it's food grade and it's biocompatible. And on top of that is the process is reducing carbon emission. And this technology is fully patented already. As a many application from a clinical hospital to paint, cement, and also building material. And we are working on a couple of like application right now. And in the university side, in R&D side, we are working on characterization chemical and physical property of these particles. And also we receive encouraging result, and we have been testing this product against a broad spectrum of microbe, including gram-positive, gram-negative bacteria and fungi. Also, we started to develop new application for this product, antibacterial cements, antibacterial drywall, and paint and plastic. Also, this product is fully registered in Health Canada Pest Management Regulatory Agency, and also Environmental Protection Agency as well. So the scale of market is $58 billion with the 6% growth, which is really good for this product in terms of the investment. And also BioSenta anticipate $10 million for further R&D development, and also a scale up and regulatory approval. Also, we successfully made a partnership with 4 Canadian company for developing antibacterial paint, cement, drywall, and plastic. And we are looking for more partnership and open for licensing agreement. So we have a great team, including Gil, CEO and President of BioSenta, and Dr. Main Hussein, a professor of the University of Calgary in the Department of Chemical and Petroleum Engineering, who is taking care of these particle development and also chemical characterization of these particle. Me, myself, mostly working on the microbiology, clinical, not clinical validation yet, but microbiology validation and testing. And also these biocharacterization happen in ACAT directed by Dr. Ian Lewis. And again, antibacterial resistance could be our next pandemic. So we have to do something for this. And BioSenta is so passionate to work on this product and make a safe and environmental friendly product that could reduce this mortality, antibacterial resistance mortality, and killing superbug. Thank you, everyone, and let me know if you have a question.
Thank you. I noticed on slide 5, you had a micrograph there, and it looked like some of the particles were aggregated. So I was wondering if you can comment on the distribution of these filler particles and its effectiveness.
I think the best person to talk and ask and answer this question is Dr. Main. But we had this kind of like aggregation in the first version of this product, and we were working on like reduce the size, and by reducing the size and adding more supplemental, so we didn't see this kind of aggregation. But more description, Dr. Main could address this kind of like a question. Maybe we can follow up after session. Thank you.
Yeah. So this antimicrobial resistance, yeah, it's a very demanding field. So how do you differentiate yourself from multinational companies? They are also working on this type of.
That's a great question. Thank you. So these are like we are working on this like these products. So this product is food grade. So compared to whatever in like a market is biocompatible. There are some value that the other product doesn't have, and also it could be utilized as additional and a complement like a complementary like a product in the cement and so on. But the problem is one is the cost, and another one is the biocompatibility and the work. And another major or important things is most of these agent that are existing, it doesn't work for broad spectrum of microbe. That is a problem. It work either for gram positive or gram negative or is antifungal. So it's very limited product that work for broad spectrum. This is the topic that we targeted that works for every microbe.
Any more questions? Otherwise, we're going to finish a bit early today. I apologize, but our last presenter isn't here, I think, unless Amir is in the audience. We have a decision to make. We have a few judges. We're going to decide which pitch was the strongest of those this morning. And so we should announce that around lunchtime, which is in about a half an hour or so. So you've got a bit of time. You can fill out the feedback forms either online or on the paper for the pitches. Also about the event, there are feedback forms about the event. You can fill those out now or later on as well. And I want to thank you all for spending your time here today. Really appreciate all your questions and the chairs and all the volunteers and the sponsors. And Ian's here is going to say a couple things about the prize that will be announced soon. But thank you very much for your presentation.
So it's great to see Mehdi and all these fantastic pitches here today. Lots of progress here from the ACAD and ADEPT programs, and we're proud to see all these new ventures coming out. So what's going to happen in the afternoon session is we're going to make our rankings on the pitches, and then we're going to give a $2,000 prize to the best pitch for today. And that's going to be presented on behalf of ACAD and ADEPT. So Michael Mingle, our North Sector Medical Director, is here to present that prize. And then the next phase of the afternoon session is about planning. So as we discussed when we first started, we're at a really exciting new point in the growth and development of the Calgary and the wider prairies ecosystem, where we're shifting away from emphasis solely on the energy sector. We're growing it in new areas. And see Tim Murphy here from Alberta Innovates is here. This is no doubt something he's very excited about, is that one of our areas of most rapid growth is in the healthcare sector, with diagnostics and medical technology being really important. We've had some major new investments in the space. We have something I don't think I can announce yet, but there's something exciting coming from in the Alberta space. We have major investments for PrairieScan, and we appreciate them for those investments here with their launch of the Alberta Center for Advanced Diagnostics is funded by Prairie's Hub. I also see NEMA here representing the Life Sciences Innovation Center was also enabled through those investments. So collectively between NEMA program and ADEPT, also Michael Callis here is growing one of the largest now biomedical engineering programs, rapidly growing programs here in Canada, and we're really proud to be the seat of that. So the long story short is that we are at a pivot point, an inflection point in our in the ecosystem here, where we're shifting towards major investments and leading in on the diagnostic sector. And the companies that we see here today are just one small bit of that representation of the new companies that are growing. Just from the ACAD program alone, we've worked with over 93 SMEs in the space. So you're seeing a small selection of those many, many companies that we're working with. And I don't know how many NEMA has got and Mike collectively between you, but we have hundreds. And it's fantastic that we have companies like Lemire and Thermo Fisher that have come to lean in. So for the afternoon session, we have to do some work, which is we've been given an opportunity to reshape how we're going to respond to the next pandemic. And with this $750 million that have been set aside for us to make this decision, we have a few things we need to decide. We need to figure out what were the problems in the last pandemic? What were the things that limited our ability to respond in a biomanufacturing sector? And what are the things that we need to do to make ourselves better prepared to respond to the next pandemic? And the context for this is that in the peak of COVID, we couldn't get access to the molecular reagents we needed to do tests. Train cars full of plastic were being seized at the US border. Flights from the US with medical supplies were being grounded. As a result, our medical professionals were doing crazy stuff like raiding the University of Calgary's freezers for enzymes. And so what the conversation we would like to have in the afternoon, and with you being our leaders in this space, is what can we do to better prepare for this next pandemic? And how can we leverage these investments to make significant change towards manufacturing independence, supply chain security, and Canadian-made products, and thought about how to integrate innovative new tech to create new orthogonal diagnostic testing mechanisms that are less dependent on Chinese and US supply chains, right? So that's the main mission for the afternoon. We have some really exciting speakers to help guide us in that. So we have our North Sector and South Sector medical directors who will be here as a part of that. And we're going to have leaders from who have direct experience in growing big companies here in Calgary. So one's Ron Hoffman will be talking to us about creating a very large GMP facility in response to COVID. We're going to have Natalie here is going to be representing PHAC. We'll have some conversations about from the national level. So very exciting panel of speakers. So stick around for that. That's coming next. And then I think next steps from here is we're going to take a break and then we're going to present a prize. Is that the plan?
That's right.
Yeah.
Yeah, so thank you. I think that was great, Ian. There's been a lot of activity so far. I thought because we have a few minutes, I might just ask our sponsors to put their hands up so we know who they are. You might want to chat with them during the break. So Innovate Calgary, anybody here from Innovate Calgary? Just mention your name, please. And just mention your name. And okay, great. Thank you. Anyone else from Innovate Calgary? So feel free to, oh, here as well, please. Okay, well, thank you all for your support and coming here today. Feel free to chat with them. They have a lot of great support for companies in the region and beyond. From ERIN, from the Edmonton Regional Innovation Network, anybody from Fisher? Who's here from Thermo Fisher? I think they're in the back here. Feel free to mention your name if you wish. A couple of you. Okay, great. Thanks for, you can mention your name if you wish. Okay, and you're here in the afternoon as well. So we look forward to your input. Feel free to meet with them as well. And then from Biomedical. Okay. And thank you for your support and for coming here today. And from Adept, we've got a few people as well. Ian, anyone else from Adept? There's a whole crowd of you, I think, around. And also from ACAD. You guys overlap a little bit. So great to have all of you here.
Everybody who's doing the coordination here is from ACAD.
Yeah. Well, and I want to thank you all for your volunteering as well. And then from Calgary Economic Development, there's a number of you here as well. So thank you. And just mention your name again. Lee Tang. And there's a few more here as well. So thank you for your support today. And then from Bennett Jones, there's a couple of people from Bennett Jones, I think. Thank you all for your support. Also from the university. Oh, hi, Peter. Thanks for coming on board today. And then from the universities as well. Thank you all for coming. Is there any questions, comments about today? We've got a few minutes if you have anything, burning issue you want to raise, any questions. Otherwise, we've got a break and then lunch at in about 20 minutes or so. Any burning issues? Otherwise, you guys are probably a bit exhausted. So thanks you all. Thank you all. We'll see you at 1 o'clock, actually for lunch at noon.
Thanks, Michael. I should say, yeah, thanks.